Oh, I don't need this. Okay. Good afternoon. I'm Cindy Hall, President of Women's Policy, Inc., and welcome to this afternoon's briefing on the rising maternal mortality and morbidity rates in the United States. Women's Policy, Inc., or WPI, as most of you know, I think, is a nonprofit, nonpartisan public policy organization. Our mission is to bring women policymakers together across party lines to work on issues of interest to women and their families. And we work very closely with the Congressional Caucus for Women's Issues, their members, and their staff. I would like to thank our congressional briefing sponsors, Congresswoman Kristi Noem and Doris Matsui, who co-chair the Women's Caucus, and Congresswoman Susan Brooks and Lois Frankel, vice chairs of the Women's Caucus. This is the 9th briefing in a women's health series we are sponsoring over several years, underwritten by the Robert Wood Johnson Foundation. We thank the foundation for its support and all of its work to improve the health and health care of all Americans through its support for research and programs working to build a national culture of health. Our thanks to our esteemed panel of speakers who will be introduced in just a moment, Dr. Michael Liu, Dr. Keisha Callens, and Dr. Elliot Main. I would like to acknowledge Dr. Nancy Lee, Deputy Assistant Secretary of Health, Women's Health at the Department of Health and Human Services. And Dr. Lee and her staff are longtime partners of our organization, and we actually will be doing a briefing with them in June. And I don't know if Bevan Albertani is here. Oh, good. Bevan is with Leuna. She's one of our members of our board of directors. This briefing is being videotaped and should be available for viewing later this week at our website, womenspolicy.org. So if you have any colleagues that missed the briefing, please share the link with everyone that you can. We really want to get this information out to the widest possible audience. We will be live tweeting during the briefing also, and we really encourage you all to join us. Please use the hashtag WPI Health. And then one final note, please don't forget to fill out the green evaluation sheets in your packets. They help us get ideas for future briefings, and also we do pay attention to suggestions to improve the series. So I am very pleased now to introduce Congresswoman Lois Capps, who is in her 9th term and represents the 24th District of California. She is a senior member of the Energy and Commerce Committee and a longtime member of the Health Subcommittee, and also serves on the Natural Resources Committee. A former Women's Caucus co-chair and longtime Women's Health Task Force co-chair, Congresswoman Capps has made maternal health one of the top caucus priorities over many years and has authored legislation to reduce maternal mortality both in the United States and abroad.
Thank you. Thank you. Thank you to Women's Policy, Inc. And to all of you for coming. This great leadership in the form of Cindy Hall and Cheryl Williams keeps us all focused on these topics. And we have some amazing speakers here. Thank you all for coming to address an important issue, and particularly to the Robert Wood Johnson Foundation for their work in helping to build and leading the way to build a culture of health, and for their support of this briefing. You know, when I was young, we vowed to leave the world a better place for our daughters. We promised to protect them from discrimination and give them all the chances that we were denied. All the chances that were taken away from us has been historical because of our gender. This was supposed to be our time as women. Yet time and time again, we found ourselves having to fight for equal rights, equal access, equal pay, and now, equal health. It's hard to believe this, but the United States is the only developed nation in the world with a rising maternal mortality rate. I think none of us really expected me to say that. I didn't either. It's shocking, but it is true. And perhaps even more concerning is the fact that we don't really know why. But this is what we do know. at least half of the maternal deaths in the United States are preventable. And after years of work by many of the people in this room, and particularly those on the panel here, we are finally turning the tide to ensure the meaningful inclusion of women and women's unique health issues in medical research. That's for starters. States like California are leading the way on data collection and intervention. These are the critical building blocks needed to address these issues. And the Affordable Care Act represents a major paradigm shift to improve access to health care, especially for women and their families. The inclusion of preventive health services without out-of-pocket costs, as well as prenatal and the care and the requirement that plans cover maternity care services, it should be, a standard, but it's amazing to realize it hasn't been. This is a game changer for women across the country. This is an incredibly important fact because some risk factors can be screened for, but only if a woman has access to a healthcare professional. Getting screened is like getting that first level of protection. Gives individuals the ability to protect themselves, to know about themselves, to fight risk factors, to notice problems early, to be able to take action. But access to care is just one step. We still need improved research on how diseases manifest differently in women and ensure that treatments work in women. It's amazing to me that in my time in Congress, it was a fact that research on health issues, heart attacks, was done on men. And we've had to work hard to get that changed. And that's just one entity, heart issues. We need to educate our healthcare providers to spot unique warning signs. They're not exactly the same for both genders. We need to support women who all too often put their families and their jobs, their kids, and everybody else ahead of their own health. We need to support them to take the time to seek care, to have the time away from work to get care, all the things that takes. We have an obligation to be a part of shaping our society's response to healthcare problems. But I believe that with our new holistic approach to healthcare, that is comprehensive healthcare services, we are on track to reverse this trend. But it's going to take all of us being diligent and watching to see how it unfolds itself and not being content with the status quo. So thank you all for taking that. And I know we're going to hear these points and others by our speaking panel. And thank you all for taking the time out of your day to be here and learn about this topic. Working together, we really can reverse this trend. We've made starts, we've made strides. We don't want to diminish the progress, but we know we're not there yet, right? We know we have a lot more work to be done. So thank you all very much for being here. Appreciate it very much. Thank you.
Thank you so much, Congresswoman Capps. You are a true champion for women's health. Congresswoman Susan Brooks is our next speaker, and she is the Republican Vice Chair of the Women's Caucus. She is serving her second term representing the 5th District of Indiana. Congresswoman Brooks, like Congresswoman Capps, is a member of the Energy and Commerce Committee and the Health Subcommittee, so we have two of the experts, and also serves on the Ethics Committee. Congresswoman Brooks has been an advocate of improving access to high-quality health care. She's the sponsor of several health care bills, including legislation to prevent prescription opioid abuse.
Hello, everyone. It's great to be here, and it's wonderful to see so many of you come out today. The World Health Organization estimates that since 1990, which actually, when I saw that, that's the year my daughter was born, my first time in a maternity ward. I don't even know if they call it that anymore. But global maternal mortality dropped by 44% since 1990. Yet that means there's still one death every 2 minutes globally related to maternal mortality. And as a developed nation, it's easy for us to think of this in underdeveloped nations and to think that these heartbreaking statistics and that these deaths are in countries outside of our borders. And in fact, that's what we normally think about. And so I think what Congresswoman Capps, what Lois just shared, and what you may not realize, though, over 600 women are dying each year in our country. Over 600 women are dying as a result of pregnancy or delivery complications. Now, Lois Capps is a champion in Congress, a nurse who came to Congress, and I love to listen to and follow what she has been an advocate of. And we are going to miss you from the United States House because Lois is retiring. But pardon, I am going to be here. When they said she's a senior member, I am a junior member, new member of Energy and Commerce, but she truly has been an inspiration to me and to a lot of members for fighting for women's health issues. I want to thank Lois, all the healthcare professionals, particularly those on our panel here today, and those of you working and joining us to tirelessly provide quality maternal health care and reverse these concerning trends in our own country. Also want to thank Cindy and Cheryl, Women's Policy, Inc., for organizing this important discussion. And thank you for just coming, the panelists today, and taking time. You are educating a lot of staffers, a lot of people involved in organizations that educate our staffs and help us promote really effective policy. And so as a vice chair of the Women's Congressional Caucus, as a woman, as a mother of two, I look forward, and I'm sure you look forward to learning from our experts. And I just want to thank everyone for coming out. This is an important topic for the country. Thank you. Thanks. Thank you. Thank you very much. Thanks.
Thank you, Congresswoman Brooks, for your leadership as well on women's health. And I think most of the audience is well aware there are so many committees working right now. There are hearings and markups, and so it's difficult for members to do anything but stop by. I am now pleased to introduce Dr. Michael Liu, Associate Administrator of Maternal and Child Health of the Health Resources and Services Administration, or HRSA, since November 2011. In his post, he directs the Maternal and Child Health Bureau, which is responsible for improving the health and well-being of all of America's mothers, children, and families. Since joining HRSA, Dr. Liu has launched a number of major national initiatives to improve maternal and child health, including initiatives working with states to reduce maternal and infant mortality. Dr. Liu joined HRSA from the University of California, Los Angeles Schools of Medicine and Public Health, where he was Associate Professor of Obstetrics, Gynecology, and Public Health. While at UCLA, he was a lead investigator for the National Children's Study and led a project to monitor and improve the quality and safety of maternity care in California. He served on 2 Institute of Medicine committees and chaired the HHS Secretary's Advisory Committee on Infant Mortality.
Good afternoon. I'm delighted to be here, very honored to participate in this panel. And let me just start by thanking the Congressional Caucus for women's issues, and especially Congresswomen Noem and Matsui, Brooks, Frankel, and Capps, as well as Cindy and Women's Policy, Inc., for hosting this event and really putting a spotlight on the rising rates of maternal mortality right here at home in the United States and what we can do about it as a nation. So as you know, each year in the United States, more than 600 women die from pregnancy and childbirth, and more than 65,000 women suffer a life-threatening complication, or what we call severe morbidity. We are the richest nation on earth, and yet we now rank number 46 in the entire world and worst among developed nations in maternal mortality. This is a national disgrace. And maternal mortality has been on the rise. Between 1987 and 2012, maternal mortality more than doubled, from 7.2 to 15.9 deaths per 100,000 live births. Okay. And maternal mortality is just the tip of the iceberg, because for every single maternal death, there's some 75 to 100 near misses. Women didn't die, but suffer a life-threatening complications. Severe maternal morbidity has also been on the rise. It doubled between 1998 and 2011. And if you're wondering what's going on, I do think that some of this could be due to improved public health surveillance over time, but many of us are really worried that the increase may be real. We know that the demographics of childbearing is changing in the United States. More older women are getting pregnant. More women are entering pregnancy with chronic conditions like hypertension, diabetes, and obesity. Obesity has more than doubled in the last couple decades, and obesity is certainly an important risk factor for some of the leading causes of maternal mortality, including hemorrhage, preeclampsia, and thromboembolism. And I want to call your attention to cardiovascular diseases and cardiomyopathy, which are becoming leading causes of maternal mortality here in the United States. In 2012, they account for about a quarter of all maternal deaths, while 4 other causes, hemorrhage, infection, preeclampsia or high blood pressure during pregnancy, as well as thromboembolism or blood clotting, account for another half of all maternal deaths. We think that cesarean delivery may also play a role, and there's certainly a place for cesarean, but cesarean delivery increases the risk of pregnancy complications like hemorrhage. And cesarean has also been on the rise. In 2014, nearly 1 out of 3 babies born in the United States are delivered by cesarean. So that's more than 1.3 million cesarean deliveries in a single year. But what's most troubling about all of these statistics are the persisting disparities: racial, ethnic, socioeconomic, geographic. Today in America, an African American woman is still 3 times as likely to die from pregnancy and childbirth as a white woman. It's a gap that we haven't been able to close for decades. We can do better than that. So what are we doing about this? Well, since 2012, a coalition of federal and state public and private partners have come together to really try to do something about maternal mortality here in the United States. In 2012, we developed a framework for a national strategy and identified 5 key strategic priorities: improving women's health before, during, and after pregnancy, improving the quality and safety of maternity care, improving systems of maternity care, including clinical, community, and public health systems, improving public awareness and education, and continue to improve research and surveillance. In 2013, we supported a coalition of professional organizations representing doctors, nurses, nurse midwives, hospitals, and others in developing safety bundles. Now, these are bundles of best practices that are designed to improve patient safety and outcomes. So that could be simulation and drills for labor and delivery staff in terms of managing hemorrhage, or checklists and toolkits in terms of preventing thromboembolism or blood clotting. And 6 bundles have been developed so far, addressing some of the most common causes of maternal mortality, and 4 more are in the works, including 1 for cardiovascular diseases. And we know that these bundles work. We know that after the publication of thromboprophylaxis guidelines by the Royal College of Obstetrics and Gynecology in UK, maternal mortality, maternal deaths due to thrombosis and thromboembolism decreased by about 60% in just 3 years. But bundles will remain as bundles unless they're actually put into practice. And that's why this last year we launched a major initiative, again, working with our public, private, federal, state, and local partners with the goal of preventing 100,000 maternal deaths and severe morbidity over the next 5 years by doing 3 things really well. 1, improving women's health, not only during pregnancy, but before and between pregnancy. 2, reducing low risk, especially elective cesarean deliveries. And 3, getting these safety bundles into every single birthing hospital in America over the next 3 years. And we think this will work because we have actually seen it work in California. And I had the chance to see it firsthand prior to leaving UCLA to join the federal government about 4 years ago. I saw a network of doctors, nurses, nurse midwives, public health professionals under the leadership of Elliot Main and others. They went around the state. They went to hospital after hospital. They did grand rounds and in-service for labor and delivery staff. They engaged hospital CEOs. They ran quality improvement learning collaboratives. And they started changing the hospital practice and policy, hospital after hospital in California. And the needle is beginning to move. Okay. So up until about 2006, California was trending with the rest of the nation. The numbers just kept going up. From California maternal mortality ratio went from a high of 16.9 in 2006 down to 6.2 in 2012. Now that's a 64% reduction in 6 years. African American maternal mortality ratio went from a high of 51 in 2006 down to 26 in 2012. That's a nearly 50% reduction over 6 years. So if we can replicate the successes in California, and that's why we launched the AIM initiative last year, we can go from number 46 in the world to among the top 10 in the world. This is a needle that we can move. These are lives that we can save. So if you want to learn more about this issue, I'd be happy to talk with you afterwards. And certainly you can reach me through our Office of Legislation. So thank you very much.
Thank you so much, Dr. Liu, for giving us such an excellent overview and setting it up beautifully for our next speakers. And we also thank you for all of your leadership on this issue and everything that the Bureau is doing and HRSA is doing. Our next speaker is Dr. Keisha Callens, who is a women's health professional at the Marion Worthy Women's Health Center and Assistant Medical Director for Albany Area Primary Health Care, AAPHC, in Albany, Georgia. Prior to medical school, Dr. Callens worked as a clinical research coordinator with the Minority Health and Health Disparities Research Center at the University of Alabama at Birmingham. The author of a monthly women's health segment in the Albany Herald, Health Beat, Dr. Callens is a junior fellow of the American Congress of Obstetrics and Gynecology and a member of several associations. She recently was nominated by Governor Nathan Deal to serve on the Georgia Composite Medical Board and serves on several appointed committees at Phoebe Putney Memorial Hospital and AAPHC. Dr. Callens.
Good afternoon, everyone. So let's just take a quick break and have everybody stand up just for a second, because I know you're eating and this happens. Just stretch. And then if you just either hug or shake the hand of the person next to you. Okay, now that we have the blood moving, you can get back to your seats. So I will apologize up front. I will try to talk quickly because I know we have a time limit, and Ms. Cheryl will put up her signs for me. But I do have a lot that I want to share, and I will try to move quickly through that. My husband, also known as my chief of staff, who's here today, tells me that I should always start with a joke when I do a presentation. But today he told me, you probably don't have time for a joke with 10 minutes, so I will be obedient for once, and that is my joke, okay? So as stated, I'm an OBGYN and Assistant Medical Director with Albany Area Primary Health Care. I would like to first of all thank Cindy Hall and Women's Policy, Inc. for the invitation to come and speak and to sit with these honorable speakers that are here. We also thank the congressional members that were present for their support and everything that we do. I'd also like to say a very special thank you to the Robert Wood Johnson Foundation. for sponsoring this and so many other events that demonstrates their ongoing commitment to helping everyone in America have an equal opportunity to pursue a healthier life. Now, I want to give you a little bit of background about Albany Area Primary Healthcare. It was started in about 1979, and we are probably one of the largest community health center networks that's in Southwest Georgia at this time. I'm proud to say that we actually offer an umbrella of services. We have internal medicine, we have family medicine, we have pediatrics, we have podiatry, we have dentistry, we have mental health, and of course, dear to my heart, OBGYN services. We have about clinics in about 6 surrounding counties, and we have a good working relationship with our primary hospital in the area, which is Phoebe Putney Memorial Hospital. Of course, with that access comes the opportunity for us to be able to work with our high-risk specialist, or what's also called maternal fetal medicine specialist. We have access to some subspecialties as well. And we have a level 3 NICU, which means that we can take care of babies that come out way too early. One of the things that's really important about community health centers is to realize that we can service the entire community. We offer services for people who have private insurance, people who have subsidized coverage, Medicare, Medicaid, and then SSI. And then also the people that fall in the middle, we serve as a safety net. We offer what's called a sliding fee scale, where based on income, patients can come in and they can also get services. And that's really been a huge segment of how we're able to serve our population. So in 2011, Georgia had one of the worst maternal mortality rates in the country, noting, of course, that it's even higher, as mentioned before, in the minority populations. So we know what the problem is. So my purpose here today is just take a few minutes to share with you my clinical perspective of what that looks like from being on the front line. And I will also tell you that most recently, Albany has been reported as one of probably the second poorest congressional district in the United States. So we really are dealing with a lot of issues there. So let me start out by sharing just real briefly that OBGYNs are very unique, not to just brag on myself, but we are, because it's kind of a hybrid specialty. We actually offer surgical services, but we also function a primary care role, and that's very important. But the thing that makes us even more unique is when we have a patient, we're actually taking care of two people. We have mom and we have baby. So a lot of times when I counsel my patients about decisions that we make, I say, Mom, our goal is to have a healthy mom and a healthy baby. We want both to go home with each other, not one or the other. And that's a real big decision point because there are times when it does not happen that way. And that's the reason that we're here. I like to think of maternal mortality as the untimely death of any woman during her pregnancy or up to 1 year after. Untimely. Something that should not occur. We should not have babies that don't have their moms around for things that we could potentially prevent. So as I go on, I'd like to share with you a couple points, and I'll try to keep it simple. My husband told me, Chief of Staff, to keep it simple. So we have 3 top things that we're going to look at. Challenges, I kind of grouped them into 2 categories, systemic and personal. Some success secrets, things that have worked in our clinical setting, and then some suggestions for different solutions. So I like to use mnemonics. So APS is how I've grouped our systemic challenges. Access. And I know a couple of people have mentioned access before. But access is a really broad umbrella for a lot of different issues, and I, of course, could talk about this for days on end, but I will try to minimize that. Things that are important to realize is, number 1, there's been a huge collapse of the hospital systems in our rural areas. A lot of hospitals are closing. When that happens, the services are not available to patients, and that sometimes limits their access to care, particularly happening in a timely fashion. The lack of transportation to utilize services. I mean, we do have services in some of our urban areas, but it's getting people to those services. I still have patients who do not have a car or live so far out, they don't even have access to the bus system or have public transportation. Proximity of services. It's not uncommon to have an OBGYN in town in some of our rural areas, or to have an OBGYN in town who will accept subsidized insurance. That's a big deal as well. The other thing is we have a limit in terms of our ER doctors and their ability to be able to recognize when a mom comes in, she's delivered probably 2 or 3 days ago, she's got elevated blood pressures, for them to be able to make that assessment sometimes, or have someone to call to say, what do you think about this lady? How should I manage her? Where can we send her? Something as simple as that. The other thing is having OBGYNs who are comfortable dealing with high-risk pregnancies. It's okay if you have what's called a routine obstetric patient, but a lot of things are not routine anymore. A lot of younger patients have chronic medical diseases. Our second area is provider shortage, and this is also another big concern, not just for physicians. We're talking about midwives, nurse practitioners, physician assistants, nurses, people who help to supplement the care that we provide to the community. I'll give you a personal example. Probably about a year and a half ago, our community health center, we actually lost 2 providers. One retired and then one moved away. So my partner and I were the only 2 providers in our busy office for 6 months. We took call 15 days out of each month. We split that service. And we have a very busy practice, sometimes up to 80 deliveries in a month. We do have our 4 midwives, but we didn't have a choice. We had to take care of our patients. So being able to recruit physicians and then also retain physicians is a big deal if it's not a fancy town. We don't live in Atlanta. We don't have, 50 restaurants that we can go to. So it's hard sometimes to recruit people to those areas. And the last, of course, a lot of you may be familiar with the social determinants of health. So I like to kind of break that down into a few things just to make it a little bit more real. Lack of industry and lack of jobs, lack of education, unsafe neighborhoods, the strain, I call it, of the minimum wage. If you're making $7.25 an hour and you take taxes out, that doesn't leave you with a lot to do anything, to get around, to move around, to make better health food choices. Sparse commodities. It's okay for me to tell my patient you should eat better, but if the only thing that's around is McDonald's, no offense to McDonald's, but if that's all that's available, then that's an issue. Inherited stress. That's something that I think that we don't think about enough. We have people that are living in situations and people that are in families where they've had stressful situations for a very long time. And as women, we know that stress affects our health in a very big way. Skinny finances. That kind of goes back to that minimum wage. But then also culture with a capital C. The anthropological definition of culture is behaviors that have been passed down from generation to generation. It's very hard to crack that code. It's hard to tell people how to eat differently when they've been doing it their whole life. That makes it very difficult. When it comes along to the personal challenges, I use the term RHP. And the R, I like this because it's R&R, not rest and relaxation, but reproductive responsibility. So that's women being able to plan their pregnancies if at all possible, work on spacing of their pregnancy, and then also being aware of their risk. I take care of a lot of high-risk patients, patients that have had cardiac surgery, patients that have had seizures, patients that have lupus, patients with rheumatoid arthritis, patients with HIV, patients with thyroid disorders. Patients need to understand the risk of pregnancy, and if they do decide to get pregnant, how can we support them so that they will have good pregnancy outcomes? Knowing your health status. If people are distressed and they don't have a job, they're not thinking about whether or not they should get a pap smear. Probably not. It's not the top of their list, and you can't really blame them for that. So understanding the pre-existing medical conditions. The last probably year and a half, I've delivered 2 patients who were on dialysis because they had end-stage renal disease. They were in their, one actually was under 30, the other one was in her 30s. That's a pretty significant effect on the health status. And then also in terms of the preventive health care, unfortunately, most women are not accessing the system till they're pregnant. Because once you're pregnant, you have presumptive eligibility. You can go in and you can get seen, but up to that point, you may not be able to. You may not have the time, as we talked about before, or the resources to do that. The other thing that's important is having a patient-centered medical home. As we've realized here recently, when you think about women's health care, it's divided into what I like to describe as 4 segments. Preconception care, where you know you're going to have a baby and you're excited and you're trying to prepare yourself. That's one segment. The actual prenatal care course, the postpartum care, and then the intrapartum care. So if you do have a medical condition like you're hypertensive, does that person get follow-up afterwards, or do you not see them till their next pregnancy, which could be in 6 months? I see that, or it could be in 6 years. So in our practice, I'm fortunate to work with 2 amazing other doctors, and we have actually 4 fantastic midwives. We keep asking ourselves, how are we making things better? How can we make a bigger difference in our practice? How can we serve more people? So after being in Albany for about 5 years, I realized here recently that I am no longer just a general OBGYN. Let me tell you, the Wonder Pets, if anybody watched cartoons, I have 2 young kids, so the Wonder Pets, okay. They sing the song, "What's Gonna Work? Teamwork." They're right, okay? A very profound statement. So now, I consider myself a part of a team of public health-inspired women's health coaches who expertly manages high-risk medical situations. That's what we do. And teamwork really does make the dream work. So I'd like to talk about what we do in Albany, and maybe we can sprinkle that around some of the rural communities in Georgia. So some of the things that we do is we offer bus tokens for our patients for when they come to their visit so they can come back to the next visit. With our office, we have a bus station right outside where we are. That way people who can access the public transportation system can get dropped off and can get picked up. We do have there's a Medicaid van that's usually available for patients that have Medicare and Medicaid, helping them understand they've got to call 3 days in advance to make that appointment. And every now and then, I've got to make the phone call. I look at the emergency contact list, and I call the family member and say, hey, I need this patient to come. I had a patient who had had cardiac surgery. She's pregnant. She missed her appointment for her echo. I called her. She didn't have transportation. And then when I did get her appointment moved, her phone got disconnected. So I called. I spoke to her grandmother, spoke to her mom, got her to come in. Sometimes you got to make that family call. Social workers, patient navigators, and even what I call patient investigators are very important because they really keep a hand on the social issues going on with that patient that prevent them from coming into their appointment. We actually started doing childbirth classes now. I think we're in our third, going on to our fourth year, where we help to educate our population. And of course, because the population that I see, mostly minority, primarily African-American patients who might not otherwise have access to that education. I have one acronym up here, long-acting reversible contraception. Probably one of the best things that we could ever offer to our patients. We do that now in our hospital. So if I am able to identify a patient what I call a flight risk, that's someone who I think I may not see again for a while, I can offer them a Mirena IUD, which lasts 5 years, or an Nexplanon that goes in the arm that lasts 3 years. That's been a huge asset, and it's identifying what patient really needs that service. County call is something that we do. A lot of the local physicians, we will share call for the surrounding counties. So usually when I'm on call, I may get a call from 1 or 2 or 3 places where I'm having to transfer a patient in because they don't offer those services there. Our administration has been amazing because they really work hard to try to recruit. So now we have 3 physicians, but in the fall, we're going to be getting another NHSC scholar. She'll be coming to join us, OBGYN. So that's going to help our workforce. Dr. Hawks, who's our clinical services director, also talks about what we call the Velcro philosophy. You got to put Velcro on people. You got to stick to them. You got to follow them. If they don't come in, you got to go find them. Or you can have the police to do it, which is what I do sometimes, if necessary. The other thing is there's a program that's becoming very popular now called the Centering Pregnancy Program. That's a really important program usually offered through different clinical settings, particularly the health department, and they really help to educate the population. So it's good primarily, I think, for our first-time pregnant moms who really need that education. Sometimes when moms are on their 10th baby, they're really not thinking about coming to a class, but it really does serve as another feeder for services that we can offer. And finally, federally qualified health centers and community health centers. I do want to say special thanks to all the people that helped to appropriate those funds to help us do what we do in places where no one else wants to do it and for people who no one else wants to take care of. We are the major providers for subsidized insurance carriers, and that's very important. And we don't turn patients away. My clinic is known for that. If we have a mom who's coming in, she hasn't had no prenatal care, she's 35 weeks, a lot of the private docs won't take them for different reasons, of course. But we don't have that opportunity. We will see whoever comes through our doors. So in closing, I want to paint a picture for you. So the U.S. military is one of the most important components of our nation's backbone. You can consider us, the medical professionals, as your medical military. I wear green scrubs to work 99.5% of the time. I only dress up for presentations like this. And I do feel like I'm on the battlefield every day. We try to prevent disease, we fight disease, we try to protect our patients. We know the problems. But what we're in dire need of are more troops and more tools. Now what's interesting is sometimes we have the troops, we have the people, but we don't have the tools. Sometimes we have the tools, but we don't have the people to deliver the services. And sometimes you just need both. And we need them even more in our rural communities. So some of the things that I've come up with in terms of suggestions or things for everyone to really be thinking about is just having more community health centers. If they're the patients they're going to accept, they're the providers that will accept patients that have subsidized insurance or no insurance at all, then we need more of those centers. And we need to start making obstetrics a requirement. Every community health center should have an obstetric provider or someone in terms of a nurse practitioner who can help to provide that service. If we don't have that in every area, we need travel teams. We need people who can go to areas where there are no centers. We need to take it to them. We need more primary care doctors, more physician assistants, more nurses, more nurse practitioners. who are willing to not just provide services, but to really integrate into those rural communities and to help optimize the health of our women. Telemedicine in the right context. If we have an ER physician who's far, far out, he can put that patient on the screen and I can say, you know what, with the labs that you have, the way this patient looks, send them to me. There's a place for that, and that can really help us to extend the reach of what we do. Promotion of services we already have. A lot of times I tell people, we have services now. We have lots of programs, but people still need the decision-making to be able to make the right choice. For example, using the long-acting reversible contraception. There's programs like Title 10, which we have in my office. You can walk in, you can say, I don't have any money, I want to get birth control. You can leave with a Mirena that costs $1,000 just because you've made that statement. There are services, but people need to be able to utilize them and know that they're available. There's another program called Planning for Healthy Babies, which is very strong about prevention. People can sign up for it based on their poverty level. They can get an annual exam once a year. They can also have availability to have contraception. The program will even pay for you to have your tubes tied. A lot of people don't even know that that's an option to them that's available. We have an HIV clinic, and also we have the health department, which helps also to provide those services. We need creative solutions to transportation barriers. We may have to go old school, and we may have to make home visits. We may have to have mobile vans, but we can't keep doing what we're doing the way we're doing it because it's not working, and it's not working fast enough, and women are dying as a result. It's important to really have doctors and providers that really care, that invest in working with patients. As I mentioned before, with the culture that we have hard codes to crack. And it takes a couple visits to gain that patient's trust so you can start setting them up for success. We need to have continuing education, of course, for our providers. As we mentioned before, they've seen success in California with just training their nurses and their doctors in how to recognize the symptoms and how to act quickly. But also, we've got to learn to identify it. When pregnancy comes in the picture, a lot of things change. Patients that, for example, have seizures or have thyroid issues, sometimes they need more medication, sometimes they need less. We have to know that so we can adjust accordingly. We need to have more support for our local hospitals. We can't let those services go away. We can't go to bed at night knowing that hospitals are closing and people don't have services and just close a blind eye to that. And lastly, and probably I could have started with this, we need strategic planning for three things. We need economic development, educational advancement, and cooperative collaborations. It's really everybody's problems. Women's health is not just a medical issue. Lack of education leads to lack of jobs, which leads to a lack of an inability to prioritize what should be important. So in closing, I would be remiss if I did not mention the unspoken existence of the barely missed maternal mortality cases. That's the patient in the ICU that keeps me and my nurses up all night, or the patient that has to be transported via helicopter to an urban center because she's so sick that we can't provide services. I want to give you just two examples very quickly. One example is about a patient that I had, probably happened about a year ago, and I still remember it like it was yesterday. She was a young patient. She was in preterm labor. Baby's heart tones went down, so we decided to proceed with a C-section. But because it happened so quickly, we had to put her to sleep. So we got the baby out. Baby was doing great. I'm on the skin, doing my nice subcutaneous closure. And then anesthesia says, I have a problem. Now, when anesthesia says I have a problem, you have a problem, okay? Because that's a big problem. So she was intubated, and so basically he said, I need chest compressions. So here I am. I stopped my closure. I'm doing chest compressions on a patient who's about 21 years old who had just delivered her first baby. And so, of course, everyone's in a frenzy. And I say to everybody, I said, we're not losing any mamas or any babies today, okay? Inside, I'm thinking, Lord, how am I going to tell this patient's mom that I just delivered her granddaughter and I lost her daughter? Luckily, she came around, and she did fine, and we got everything worked out, and I put a Nextsplit on her arm so she won't be pregnant for 3 years, so I'm good. But those near misses are real. My partner had a case also recently where a patient came in. She was also very young, first pregnancy, and had very, very, very high blood pressures. We call it malignant hypertension, just so high. You give medicines, nothing's really working. And she decompensated very quickly. In a matter of hours, she started bleeding from her gums, her nostrils, her IV sites, everything. So we had to give her blood products. She had to have an emergency delivery. The baby actually did not make it. She was intubated for a couple of days. She ended up on dialysis for a couple of times as well. She eventually also did well. She would not take the Nextsplit, so I do have to worry about her. But these are near misses, and I can give you lots of stories of that. So even though we have numbers of what that mortality looks like, there are a lot of other cases where the patients do make it and they do okay. So in closing, I thank God that we have some really, really, really good providers and nurses and support staff and health networks who work tirelessly and selflessly on the front line to take care of our women. If it were not for them, I don't even want to imagine how much worse things could be. Thank you kindly for allowing me to share a tiny snapshot, kind of like a pendant-sized photo of my world. And despite the challenges, I would choose no other way to spend my working days. Thank you.
I don't know about everybody else here, but I will never say I have a hard job again after listening to that. Thank you so much for sharing the challenges that you face on a daily basis and really giving us a perspective of what it's like. And also for so many solutions too. It was really a great presentation. So thank you. I think I'm screwing this up. I'm going backwards. There we go. Our last speaker is Dr. Elliot Main, who is the medical director of the California Maternal Quality Care Collaborative and has led multiple state and national quality improvement projects. Dr. Main also is the chair of the California Pregnancy Associated Mortality Review Committee, a position he has held since its inception in 2004. He currently is a clinical professor of obstetrics and gynecology at both the University of California, San Francisco and Stanford University. For 14 years, Dr. Main served as chair of the OBGYN department at California Pacific Medical Center in San Francisco, which has 5,500 annual births with 103 OBGYN physicians. Dr. Main has chaired or been actively involved in multiple national committees on maternal quality measurement.
Thank you for that nice introduction. What we're going to talk about today is really the culmination of what Dr. Liu and Dr. Callan were talking about, which is the collaboration between policy, public health, and clinical medicine, because that's the only way to advance to make any progress in the issues that we're facing. We've tried in our fragmented medical system to do it one way or the other, and as you can see, we've gotten down to number 46 in the world, and that's not where we need to be. I started off in this effort as a high-risk obstetrician, so I'm the physician that these very terrible cases would be referred to in a tertiary center. Then we went out and worked with the smaller hospitals in our community and started up from there, and the state of California asked me to chair the maternal mortality review for California. California has 500,000 births a year, 1/8 of all the births in the United States, so it's a country size in and of its own right. In our maternal mortality review meeting every several months, we would look at 15 maternal deaths at a time in detail. After the first couple of maternal deaths, you really start to see first of all, it's a very emotional thing to see, to go through all the details in the medical records, the coroner's reports, the reports from the families and partners. But you start to see patterns, and you start to see opportunities to change the system. And that's really the way I wanted to lead our committee, was not so much that it was an epidemiology effort, but it was really an opportunity to change care. And that's really the driver that we've taken then in our California Maternal Quality Care Collaborative to start to change the numbers that you see here. This is the point we were when the state asked us to start doing in-depth reviews of maternal deaths and to see what we could do to change that. What we saw immediately with those opportunities for improvement was that there were a lot of preventable deaths. The box shifted slightly here, but the top two lines represent hemorrhage and preeclampsia, which in California, which is the middle, 70 and 60% of those deaths were preventable through better prenatal care, through intrapartum care, or even in how we handle them postpartum. This has been supported by data that the CDC did in the state of North Carolina over a number of years, and in the United Kingdom in their confidential inquiries of maternal deaths, which we used as a standard for designing our maternal mortality reviews in California. It is probably the world's leading approach to reducing both mortality and morbidities. The ability for preventability and the lessons that we learned from those, and the recognition that hemorrhage and preeclampsia were not only two of the leading causes of maternal death, which is that first column, mortality, 1 per 10,000 or so. See, cardiac disease at the very bottom is a quarter, as Dr. Liu was speaking to. Hemorrhage and preeclampsia in California added up to about 25% together. But when you look at the near misses, the ones that in the train, the ones that end up in an ICU, you get a little different distribution. Now you're seeing about 50 or 60% of the ICU admissions are hemorrhage and preeclampsia. And if you look at a little broader definition that the CDC uses for morbidity or severe complications, should include transfusions or hysterectomies, things like that, which now is 100-fold higher. So if you look at the red column, that's mortality, 1 to 2 per 10,000. 10-fold higher is near misses, ICU admissions, 1 to 2 per 1,000. And severe morbidities is 1 or 2%, 1 or 2 per 100. And now 80% is hemorrhage and preeclampsia. So these were preventable causes, these were frequent, and these were the major causes of morbidity. And so those were the reasons that those were the first ones that we worked on in terms of developing toolkits and bundles to work all the way from prenatal through delivery on. We started in 2009 with hemorrhage, with a multidisciplinary task force from all over the state of California. Turned that into a toolkit, and I'll define what we mean by these in a moment, and then started rolling these out throughout the state. We did the same with preeclampsia a few years later, and this is where we started to see the differences in outcomes. What's interesting about hemorrhage, which is the most common issue, is that it's all about teamwork at the end of the day. It's all about nurses, obstetricians, anesthesiologists, blood bank working together. And that actually sets the stage for dealing with all the other emergencies that you see on labor and delivery. If you can handle hemorrhages well, you can handle most everything else well. So the outcomes that we've seen in California, which is 1/8 of the births, are now being replicated with the AIM program that Dr. Liu introduced, which is a cooperative agreement with what I'm going to describe as the Council on Patient Safety in Women's Health Care, which is staffed and based at the American College of OBGYN. But it does involve every other professional group interested in women's health. So this is vice president or above leaders from the American College of OBGYN, the Nurse Midwife Association, the Nursing Association, the anesthesiologists, and many, many other groups. But critically, it's not just professional organizations. As I said at the beginning, to work on this, you really have to engage not only the professionals, but the public health folks and government agencies and both, basically anybody we can think of. So this is engage the hospital associations. There's several hospital associations, big hospitals in the United States. AMCHIP, of course, and ASTO, because engaging our public health leaders in every state is critical. CMM, the Center for Medicaid and CHIP Services, or CMCS, has a big program now for working on interconception care and postpartum care, and including LARCs and other long-term contraceptives. CMMI we've engaged with their hospital engagement networks to work on preeclampsia and hemorrhage. This is one way of getting into every hospital around the country. That's part of their overall reduction of harm campaign. I work a lot with the CDC, and they're promoting perinatal, statewide perinatal quality collaboratives. Right now that's in 6 states, and we hope to promote that even further with a combination of support from Dr. Liu and from the CDC. But importantly is the development and support for state maternal mortality review committees. You don't know what you got until you study it, okay? And those faded away in the 1940s and 50s. We did not have one in California until the public health department saw that the numbers were starting to rise, and we then instituted one. Not only is it important for the numbers, but it's important for the stories. Stories drive as well as numbers drive. As you heard a spectacular discussion just a moment ago, I'm going to talk about numbers. She talked about great stories, and you need both to affect change. So what do we mean by bundles? Classically, a bundle is a collection of things wrapped up all together with a bow. What we typically have used them for in medicine now is a collection or 10 to 13 best practices for improving safety in maternity care that have been vetted in large quality improvement collaboratives. So these are proven practices that we want to bundle up together that involve everything from prenatal care onwards. The goal of moving those into practice. The hemorrhage bundle was the first one out the door. It came out in the national one in 2015. Very multidisciplinary. It started from readiness, recognition, response, and reporting with elements on each. And again, throughout the course of a woman's pregnancy and postpartum. As evidence of widespread adoption, this was published simultaneously in 4 different specialty journals, leading journals in the Obstetrics and Gynecology Journal, the Nursing Journal, the Midwife Journal, and the Anesthesia Journals. Okay, all at the same time. That had never been done before. So what do we mean by a toolkit? There are several different definitions of a toolkit, including, and the second one is a fixed set of procedures, guidelines established to ensure a desired result. And these are really the details behind a bundle. A bundle is basically a skeleton of outline of these are great things to do, but a toolkit is all the examples, all the policies, procedures, pathways, guidelines, checklists that you would want to have to actually implement the bundles. So these would be the guide for bundle implementation. We in California and New York both have been working on these with a head start. We had funding from Merck for Mothers to help do this, and have been able to create a lot of resources for use for other states. The bundles that are out there right now, the safety bundles for hemorrhage, hypertension, venous thromboembolism prevention, safe reduction of primary C-sections, and patient and family support. That's a huge issue. You can save a mother, but they can be traumatized, or the family or the partner can be traumatized with PTSD for many years thereafter. So that's something you want to be able to work on from the beginning. And the same is true for staff who may have had a serious event involved. They can be traumatized for a long period of time. We have some additional ones under development that will be coming out this year, including a focus on reduction of disparities in maternity care. But you can have a bundle, you can have protocols, but they don't do any good if they sit on the nurse manager's shelf, which is what a lot of protocols do. So it's really about changing practice and indeed changing the culture of a unit. We talked about culture, about things being handed down. That's the way it works in medicine too, not just in the family. Things get handed down from generation of physicians within a unit. So this is really about putting together groups, and there's 2 types of collaboratives, putting together groups of providers, hospitals, working on a typical improvement project, or it can be a group of diverse organizations all working together. So like what we have here today, where you have government and healthcare providers and agencies and legislators all working together. This is a little hard to see, but this is what was the success story for early elective delivery, which was a big project that we did starting about 8 or 9 years ago. And it's led to a reduction of 70-80% in early elective deliveries, but it involved all these different types of organizations working together, including the Joint Commission, CMS, professional organizations, public policy leaders, so forth. The states that are currently involved in AIM are shown here. Oklahoma, Maryland, Louisiana, Florida, Michigan, and Illinois. In the third column, we're transitioning, hopefully, California and New York into AIM, even though we had a head start, was we're working on the same bundles. We also have health systems, Trinity, Premier, and the National Perinatal Information Center, NPIC, who are putting together collaboratives to work with us. And we have a number of states that are quite interested, that are on the runway, so to speak, New Jersey, Mississippi, South Carolina, and we hopefully we're going to include Georgia and Texas. But when you add these up, these 16 states, not even counting the health systems, this is 2.4 million births, okay, which is 60% of the births in the United States, 4 million births in the United States. So that's pretty exciting that we would go there. So we have to work at the top and we have to work at the bottom in terms of top being government programs, bottom being actual delivery of care services to make an impact here. And we have the opportunities with bundles and toolkits and collaboratives, but it's really a partnership of public health, clinical medicine, and patients. So we're going to stop, and I think this is question time, but I can't leave without talking about my home team. Yeah, my view of the Golden Gate Bridge. Tonight they go for the record of the most wins ever in a season tonight. So I'll be on an airplane going home. Okay, thank you. Okay.
Thank you so much, Dr. May, for your groundbreaking work. And we certainly are very impressed with everything happening in California and do hope that it is duplicated successfully in many other states. We will go to brief discussion, and we have a microphone right there in the center. So if you could come and give us your name and affiliation. If you have a comment to make, please keep it very brief.
Hi, my name is Adrian. Is it on? My name is Adrian Griffin. I'm with Postpartum Support International. We help women who have postpartum depression. So in all of these slides, we saw all kinds of physical causes for maternal death. I want to make sure that we keep mental health awareness as well. We know that suicide is the leading cause of death in the first year postpartum. Up to 20% of deaths in that first year, maternal deaths, are from suicide. Women in the postpartum period are more likely to use lethal means to take their lives than at any other time in their life. So I know that there recently was a new safety action bundle on mental health. I just want to make sure that everybody in the room realizes that this is yet one more thing that we need to be looking at. All of those physical causes combined that we screen for during pregnancy, preeclampsia, gestational diabetes, all of those things, in total do not equal the number of women who experience anxiety and depression. So I want to make sure that that is addressed. And Dr. Liu, I'm not sure if I couldn't read on your slide those causes of death, and I was wondering if that was on there.
Yeah, and just want to thank you for calling attention to mental and behavioral health issues. And certainly, kind of one thing that's kind of increasingly alarming to us is the increased number of deaths due to opioid overuse in the postpartum period. Now, we're certainly paying attention to that. We think what may be going on is that during pregnancy, mom gets to the front of the line, but that quickly they quickly kind of lose that priority once the baby's delivered, and yet the same mental, behavioral health issues, the same social pain continue, but without attention, without treatment. So certainly I appreciate you calling attention to mental and behavioral health issues, which I think are major drivers of maternal mortality and morbidity, and certainly the disparities of maternal mortality and morbidity. So thank you.
Thank you.
And I'd like to just second that as well. For Georgia, when they list the top 7 things, actually mental health disorders is right up there. So she's definitely on point with that.
And we actually will be looking at this in June at a briefing. So, Nancy.
Hi, I'm Nancy Lee. I'm the director of the Office on Women's Health at HHS. And I used to deliver babies a very long time ago, and I have some of my own PTSD. As you started talking about this, I started remembering my scary ones. not maybe every, but almost every woman who dies, there's a lawsuit associated with that. Young women don't die in stuff like this without lawsuits. And so I would think that the people who cover the hospitals and the physicians for their malpractice have an important stake in this whole issue. And given that money seems to drive a lot of what happens in our healthcare system, is there a way that we can engage in the insurers and the quality control people to help us make sure that every hospital not only has the bundle on the shelf, but is actually doing what the bundle says?
So in AIM and in our collaboratives, we have engaged the medical liability carriers, because just for those reasons that you've said. And they are people that hospital administrators listen to, shall I say. And they've been very useful in helping institute drills and safety practices in sort of raising the issue to a level that it's recognized. Maternal deaths, though, are still pretty rare, 1 in 10,000. So what really drives the malpractice carriers is the severe morbidities, which are, 10 or 100-fold, depending on in that kind of range, much more common. The moms who go to ICUs or so forth, those are also pretty serious events that are costly and can lead to litigation, and there's more of those. So there is a union there. There is a natural partnership there.
Good afternoon, everybody. So I am Dr. Joya Career Perry, and like the woman in front of me, I used to deliver babies. I'm an OBGYN by training, but I am the president of the National Birth Equity Collaborative. So I trained at Charity, and in 2001, there was a big switch to no longer having outpatient, being able to labor people from home when you're VBACing, right? So this, in the South, that means black women don't get VBACed, okay? Because most private practitioners are not going to come in and stay and labor with you for 12 hours. So that's a truth that we need to just settle in and understand. So our C-section rate is about 40%. So when we say, black women are obese or they have all these illnesses and preeclampsia, know that we're also now operating on them a lot more. And if we're more afraid of uterine rupture than we are of preeclampsia, we're going to keep having the same outcome. So at some point, we look at how we decide when you should VBAC and the risk factors for people based upon their socioeconomic status, and to reevaluate, because it's very different to do that if you're in California than if you're in rural Georgia. So that is my comment.
Though we have a huge amount of very small rural communities in California. We have a lot of mountains and a lot of tall trees. The VBAC is an issue everywhere, and it's 40% of the hospitals in California no longer offering VBAC, and that's becoming now a public issue, with women rightfully picketing hospitals, so forth. I think we have to work with the American College and the insurers and so forth to get a little bit better way of establishing the guidelines. You don't have to have physicians in the hospitals for early part of labor, for example. That's not when the uterine ruptures happen. They happen at late in labor or when you're complete and pushing. So there's some common sense approaches there, but it's the whole issue about the burden of cesarean birth really goes back to that first labor, and that's why the efforts that we're doing, which I didn't talk about today, on first labor, first C-section reduction are critical. Because right now, 90%, if you've had a C-section, 90% of all your future births in America are by C-section. That's 8% VBAC rate. And that's, so the most pregnant opportunity, if you were, is to prevent that first C-section, because then second and third vaginal births are much, much easier anyway. So how do you approach that in Georgia? Or in your center in Georgia? Because I'm afraid to say that you're not representative of all the communities in rural America, unfortunately.
Yeah. So we have similar policies that require the physician to be in-house for that entire labor, and that does make it difficult for us to offer a VBAC. So we really don't do it a lot. Granted, if I have a mom that it's her 9th baby, she had 1 C-section, she delivered 7 others somewhere else, and she comes in labor, I'll sit there with her and I'll wait, and then we can deliver. But what's also happening is the reasons that people are having that first C-section also are an issue. We're inducing people a lot earlier because they have chronic medical conditions, and that sometimes the setup of the cervix is not ready, then you're setting them up for a C-section. So managing those medical conditions as well and deciding on that first delivery are important, but sometimes our hands are tied. That happens too.
Hi, my name is Dr. Naomi Bohmslag, and I'm clinical professor at Georgetown Medical School, but I'm not working there now. I wanted to, and I've worked a lot in developing countries, Malawi and South Africa, where I come from. And I was appalled to find what was going on in this country, considering all the resources and all the wealth in this country, and looking at what poor people did in desperate situations. And so I was looking through my cupboard and I found a maternity kit. This is a maternity kit from Malawi. It consists of a tie for the cord, soap for sterilization, and a razor blade to cut the cord. And I'm mentioning this, that there's a lot of room for improvisation. There's a lot of room for doing other things than having these complicated technical arrangements and ways to try and get women to clinics or not. We don't even know how many women deliver in their homes or in the street or in a car or in a taxi. We do know hospital statistics, but as far as I know, I've not seen figures for births outside the hospital situation.
Those are collected on birth certificates, because every birth in the United States does have a record.
Yeah, but we don't know. How much is it?
It's about 1% right now. It varies state to state.
Oh, I can't believe it. I accept your word, but I'd like to check it.
Mm-hmm.
I think in Georgia, a lot of people don't manage to go. They go with midwives, and I don't know what happens after that. Are you talking for California, or are you talking
US
for
total.
the country?
U.S. total.
Okay.
Actually, the highest states with home births are Washington and Oregon, and that's about 3-4%.
Okay.
I think what happens a lot in Georgia too, we do, I know in my community, we have a lot of women coming in who have had no prenatal care, but they do show up, and usually we're like catching the baby as we're rolling down the hall. That does happen.
Or getting a birth certificate.
Right. So.
Thanks.
Mhm.
Thank you. Before Rita speaks, I should just mention she is editor-in-chief with Women's E-News, and I was going to thank her for bringing us to Dr. Callens. And so if any of you are not a subscriber, you should be. It's a daily report on a wide range of women's issues. And had it not been for Rita's wonderful publication, we would not have known about Dr. Callens. So please.
Oh, with that introduction, could I ask more than one question? All right, you just pick which ones you want to answer.
Fair enough.
Okay, I wrote them down. Dr. Wu, we've talked about this before, but we actually don't know what the maternal mortality rate is in this country because 9 states aren't cooperating. So we once had a conversation that said, well, what would you guess was the actual rate? And it's higher. It's like in the 20s, right? So I think we should call, maybe it's been fixed since we talked, but I don't think so. Or has it been?
Yeah, there are certainly efforts going on in terms of improving surveillance of maternal mortality. Currently, there are two systems that are going on. One is using death certificate with the pregnancy checkbox,
Right.
which often leads to an overestimation of maternal mortality. And the other effort on the part of CDC is to link the birth death certificates, and that also extend accounting the maternal deaths for up to 1 year. And so that's why you see these numbers somewhat differently depending on what numbers are being reported. I think there's now a really concerted effort led by CDC in terms of really improving our surveillance system. There's also efforts in terms of trying to develop a national system for maternal mortality review, a kind of online maternal mortality review, moving us closer to what UK has done around their confidential inquiry into maternal deaths, which is, I think is long overdue.
It is actually surprisingly hard to measure maternal deaths in defining the maternal death. And we have 50 different jurisdictions, 50 different states, not that eager to share all their vital data as it ends up. But for example, where after a week or 2 or 4 or 6 weeks is it still a maternal death? Is it pregnancy related at 9 months or 12 months out? Data that we have in California, for example, suggests that suicides are a fairly common occurrence in that first year, but they are fewer in that year than any other year in a woman's reproductive life. So are they pregnancy related? So the rate of suicide is lower in that year after birth than in other years, but they occurred within the year of birth. So it's tricky business.
Oh, very tricky.
One more.
One more. Okay, Dr. Cullen, I'm not going to ask this question publicly because it would get you in trouble politically. So, Dr. Main, I'll ask you after. Dr. Main, what is the strategy that you've put together to reduce the health disparity, i.e. the higher rate of African American deaths?
I'm not sure that's going to get anybody or all of us in trouble at the same time, but it's when you look at the African American disparity, which is 3x, that's actually a higher rate of disparity of all the public health measures out there. When you look at prematurity rates, you look at cardiovascular death rates that are all higher in African Americans, they're 1.5 to 2x higher, which is a big number, twice as many. But maternal mortality is 3 to 4 times. And that really stands out among all of the statistics that we've talked about today as the one that demands the most attention. Now, there's not an easy answer to that. We showed we could reduce it, but even when we reduced it, we still had a 3 times higher rate in California. And that's really undergoing intense study and intense work, but it's involves a lot of the things that you talked about, but I'm sure you could add to that. Mm-hmm. What are your thoughts?
So I think that there are definitely is a lot of room for improvement. I think that what works for the group does not always work for specific individuals. And I think a lot of times we're still using these generic things that we're applying to everybody. So I think probably the most important thing, because I know we're running out of time, is to work on individualizing what we do for the people who need it. And I don't think that we have evolved with our strategies as well as we could to account for the differences. There is a problem with health equity and looking at those background issues that affect the decisions people make. They're not the same for everyone. And even within the African American population, there are differences depending on whether or not they're immigrants or what their background is. So I think our best bet would be to really work on individualizing what we do.
One of the things that you said that really caught my attention, though, was the efforts that you're making to build trust in the system. Because I think that's, when I reviewed records of maternal deaths and did interviews, there was a lot of conflict sometimes between African American women and their providers, and there was a loss of that trust. And I think that's going to be a key element going forward.
If I may, Rita, I do want to respond to this question because this is a question that kept me up at night for a very long time. And I do think that for us to really do something about the disparities, there's two things that we really have to do. Number one is to really improving women's health before they get pregnant, and that means improving their access to prevent health services, better management of their chronic conditions, but more importantly, addressing those social determinants that we talked about, the housing, the poverty, the violence, the education opportunities that these social determinants operating across the life course are the real drivers of health disparities. And the other is to improving the quality and safety of maternity care. We talked about prenatal care, we talked about intrapartum care. I just want to, again, call your attention to postpartum care and follow-up. And this is especially important because one thing that's really concerning to me is this rise in cardiovascular disease, and especially cardiomyopathy, which often don't present in the hospital, but may often present months after delivery. And the lack of access to high-quality postpartum follow-up, the lack of access for that continuum care across the life course, I think is a major driver of disparities as well. So let's make sure we improve women's health before they get pregnant, and let's make sure that they get access to high-quality services throughout their life course and not just during pregnancy.
I would be remiss if I came to Capitol Hill and didn't point out that all these programs that we're talking about, rural health, quality collaboratives, so forth, is being done on a shoestring. There's very little money that's been spent on supporting any of these efforts. So.
All right, well, those were very helpful answers, and it's obvious this is very complex, and trying to tackle it in an hour and a half is ridiculous. We hope this is not going to be the first look at this issue. And we have done a number of briefings on global maternal deaths, and some of the issues are similar. Certainly, transportation has always been a challenge, but many of the others as well. So we do hope this won't be the last look at this issue. And also, I would be remiss if I didn't mention there's a Congressional Caucus on Maternity Care. It's new as of about 6 months ago. And the co-chairs are Congresswoman Jamie Herrera Butler and Lucille Roybal Allard. And both of those members had planned to speak here, but because the Appropriations Committee, they're both appropriators, unfortunately, because they would have certainly benefited, but they're big advocates too. They were having a hearing at the exact same time, so we're not able to be here. But Jessica Wixon in Jamie Herrera Butler's office, and Debbie Jessup in Lucille Roybal Allard's office, for any congressional staff are interested, please reach out to them. Well, I want to thank our speakers for their excellent presentations. Let's have a round of applause. I think we definitely have a better understanding of maternal mortality and morbidity in this country after hearing from the three of you, and how we can reverse this trend, that there are some things that can be done. I want to reiterate our appreciation for the Robert Wood Johnson Foundation and their support for underwriting this entire briefing series, and also to our congressional co-sponsors and staff. And then finally, my thanks to Cheryl Williams, who's right here, and Claudia Umania over here, of our staff for their help to make this briefing possible. Thank you so much.